Hello folks, it's Dr. Chris here from Apex Soft Tissue and Spine, and in this video I get to sit down with Dr. Michael Vanchieri of Wildcard Spine and Sport, and we are going to be talking about sciatica. So it's a big topic, it's a common topic, it's something that people want more information about. And this video is just going to be an update because we actually did a video which is about 2 years old now, and some of you may have seen that on this channel, and some things have changed in 2 years. We're actually managing and treating sciatica and sciatic-like cases a little bit differently to what we were back then. So we're just going to provide a little bit of an update to some of that. We're just going to cover off on why sciatica is such a common problem, but it's actually not a simple problem. And it does have a lot of detail to it to get the right outcome in some really difficult cases. So we're going to talk a little bit about that. We're just going to touch on what is a true sciatica, which is coming from the spine, versus a sciatic nerve entrapment, which is happening outside of the spine, which you may have heard us talking about before on this channel. We're going to do our very best to answer a couple of frequently asked questions that we get from patients, so hopefully that'll be helpful. If you would like to connect with Dr. Mike at all, he is at Wildcard Spine and Sport right here on YouTube, and he's also on Instagram. So that's enough from me. I hope you enjoy this talk. We'll see you on the next one. Dr. Mike, it's good morning in Sydney. I guess good afternoon in New York.
Good afternoon.
It's been 2 years and there's been a lot that's happened in the last couple of years, and I think it's time for an update. There's been a bunch of people that have joined the channel recently and shown a lot of interest in today's topic, and I mean, for good reason, right? I think this is a problem that affects a lot of people, and the amount of response that I've seen to some of the content that goes out, it's always at the top of the list. It's the thing that really gets people buzzing the most. You get the most questions coming back. You get the most, I guess, harrowing stories of people that are having really, really devastating experiences with chronic pain. And it all sort of seems to come back to sciatica in a high percentage of these cases. There's a lot of suffering going on with that. And it's probably fair to say that as a profession, or even more broadly as a non-surgical community, we haven't done a great job, and probably in the last 2 years still not doing a great job broadly, hence the reason why a lot of people are still suffering more than they need to be. So I think let's give a bit of an update on what's happened in our neck of the woods over the last couple of years, because there has been some new things come along, which I think has really been great in terms of pushing this forward. But this has just been something that I've noticed where, we publish some content that is related to sciatica, and I almost don't even like to use the word sciatica, right? Because it's such a broad term, and all it really tells us as a description is that there's a symptom either in one leg or both legs, and it doesn't tell us too much more than that. It should really mean that we have nerve pain associated with the sciatic nerve, but there's just so many things that can cause symptoms in the leg, and it may or may not involve the sciatic nerve. It is a common thing, but it's just doesn't tell us enough. So in our practice, we have to dive into a lot more detail. And a lot of people, I guess, attach to this label of sciatica. And my question for you is, you run a busy practice, you see a lot of people coming in. Without going into specific numbers, but I guess just broadly, what sort of proportion of those people are presenting with sciatica, and how many of those people do you think have just kind of suffered for too long by no fault of their own?
That's a great question. Sciatica is a particularly frustrating symptom set for people because it frequently goes unfixed for extended periods of time, right? You think sciatica, I have to go get back surgery, and most frequently that's not the case. But yeah, I mean, at the end of the day, I probably get 60 to 65% of my patients in the clinic as, lower back and hip patients. And of those 65%, you're looking at somewhere in the, oh gosh, I don't know, the 60 to 70% range have some level of, radiculopathy or sciatic nerve like symptom set or sciatica symptom set. So it's tough for me to say because, as you know, right, what you classify as sciatica is not necessarily what a patient classifies as sciatica. So I would say, again, 60% of my lower back and hip people have objective sciatic nerve problems. Now, whether or not that displays itself as the traditional descriptor of sciatica is another thing. Because, as you said, right, sciatica it's not a diagnosis, it's a descriptive symptom set, right? Just like carpal tunnel syndrome, just like thoracic outlet syndrome. It's technically sciatica syndrome is what it should be. And as we've gone over before a couple of times, a syndrome is a descriptor of symptoms. So basically, yeah, 60% of my lower back patients end up having some level of sciatic nerve involvement.
Yeah, I really love the way that you kind of wrapped up the last video that we did, because the message that I think you really wanted to impart on viewers is that sciatica is not simple. And if we use that term sciatica, it does sort of simplify it, and then it kind of gives the idea that, maybe we can jump on YouTube and find some stretches that'll cure it, or maybe you can just walk backwards for half an hour a day and that'll fix it. Or like, there's some crazy stuff.
Just walk backwards, you'll figure it out. Yeah, eventually it'll just go away. Yeah, it sounds very simple. It sounds like you just fix one quick thing and life is good and your symptoms go away. But it's the biggest nerve in your body, right? It travels the longest distance. It starts in multiple places and kind of conglomerates, and then it splits in multiple places. So, that symptom set can be a result of any level of dysfunction along any part of the actual sciatic nerve. So it really takes a skilled diagnostician, a skilled clinician, to try and break it down well enough to figure out, okay, what's going on? Is this a nerve entrapment? Is there a disc pressing on a nerve root, right? What's happening? Is it going to be an easy fix? Do you need surgery? Because there are people, right, that have sciatica that just objectively need surgery. It's less than what your local orthopedic surgeon will probably say. It's more than maybe even we want to say, right? Because we're biased in our own ways. But yeah, sciatica is infinitely simple and infinitely complicated. And you don't know how complicated it is until you get to maybe our level of knowledge or a clinician's level of knowledge. It's like you don't know what you don't know until you know enough.
Yeah, and to break that down a little bit, one of the ways that I sort of try to approach this with patients initially is we've got to discern what symptoms are spinal in origin and what symptoms are essentially extraspinal. So you touched on a nerve entrapment, which is what we call a peripheral nerve entrapment of the sciatic nerve, which is basically where that nerve gets stuck after it's left the spine. So we can have a true sciatica, which is going to be likely to be a disc injury in the lower back. We could have some advanced degeneration where there's some arthritis essentially that is pressing on a nerve, that sort of thing. Or we can then have some peripheral nerve entrapment, and this is not something that's new. We see this all the way through the literature. If you ever want to look it up, just go and Google something called deep gluteal syndrome, and you can even look it up on YouTube. There's neurosurgical videos of actually.
I would not suggest doing that if you have a queasy stomach. If you're easily upset, don't look it up.
You can actually go in and see this happening in real time, where they are using an endoscope and actually breaking down fibrovascular bands around the sciatic nerve in the back of the hip. It's crazy. But this is where this nerve gets stuck, and then this can cause symptoms as well. Now, you can have either a spinal problem, you can have a peripheral nerve problem, or you can have both. And that's pretty common as well. So this is where the detail becomes important, because it's not just in the back of the hip that this nerve can get stuck. There's other places all the way down the leg as well. And this is where, you know, in the last couple of years, with some of the changes that have happened in our practice, when we last sat down and talked about this video, we were probably a little bit more limited in terms of what we could actually treat non-surgically, because most of it was done with our hands. And so we could only access what we could access with our hands. And if that nerve or nerve tissue happened to be entrapped in a location that we couldn't physically get to with our hands, it was a rough time to try and deal with that, if not impossible. But we've actually been able to shift a little bit more now towards using radial shockwave therapy to address some of these nerve entrapments. And that's actually giving us the ability to get at some areas that have otherwise been a little bit harder to access. Mike, how have you sort of found the shift now sort of more towards shockwave? And it's not 100% of the time. Sometimes you do want to use your hands, but how have you found that in terms of, I guess, if I can use the word, cleaning up more of this nerve entrapment?
Yeah, you hit the nail on the head. It's just we're able to access more, right? You can only get to a certain depth, right, with your hands without causing either physical comfort to yourself or physical discomfort to yourself or physical discomfort to the patient. You know, with Shockwave, we can get almost, 50, 60 millimeters deep. So that kind of opens up a lot of the nerve that is inaccessible, mostly in throughout the hamstring. So like the actual hamstring bellies, we could get to it with our hands at the glutes, right, where you're describing deep gluteal syndrome, because there's like just enough of we'll call it a break in the glute tissues to where you can sink down. We could get it basically at the popliteal fossa behind the knee. So if you guys go and you feel behind your knee, there's like a nice little dead space in through there. I was even able to get a little bit of the fibular / peroneal nerve at the calf, right, with the tool. But now it's like we can basically trace that nerve from the nerve roots all the way through the glutes, down the hamstring, into the popliteal fossa, where it splits into the tibial and peroneal nerves. And you can basically trace that thing all the way down into the feet, right, where it's going to, I don't want to get too far into it, but we could take it basically all the way down to your feet and effectively treat it. So that's increased the amount of sciaticas that we can positively influence. Oh, goodness, probably about 30%. There's a lot more fibular nerve entrapments, which is, again, a branch of the sciatic nerve than I probably initially had thought about. And we're certainly able to fix a lot more of those now. So yeah, it's been a pretty incredible discovery, right? Armed with the clinical knowledge that we have and a tool that enables us to treat more and more and more sciatica. It's been a wonderful experience.
Yeah, it's a good point that I think, this has been a really good development for us and for patients in terms of the treatment that we can do. But it's ramped up the level of detail as well, because it's opened the door to being able to treat more things. And this is an important point for patients, I think, just to understand, the sciatic nerve, as it comes through the back of the hip, it's about the width of a pinky finger in a lot of people. It's the thickest nerve in the body, so it's quite big. And then that's going to supply a lot of the rest of the leg all the way down to the toes. But you have branches that come off of that. And it only takes one of those branches to be entrapped and not sliding and not gliding and stuck with it, almost like a little bit of blue tack. And then that can be enough to generate symptoms and have you sort of say, my sciatica is flaring up. It only takes one little spot, but you can have that one little spot on top of a disc injury. And then that little spot of adhesion is actually going to prevent that disc injury from being able to heal effectively. So there's so much that can happen in this whole track through there. And that's why we sort of say that sciatica as a diagnosis is a pretty weak diagnosis. And we still use that word. We still talk about it because when we say it, we all know we sort of all mean the same thing and we get it. But in a clinical sense, it's not going to be something that you're going to see in our clinical notes, right? We're not using that to, and even with I think communications with a patient as well, we really want someone to understand the totality of what's going on for them rather than just bundling it all up as you have sciatica.
Yeah, the only reason I use sciatica is because the person who's listening right now expects, right, me to use sciatica, but it has, I don't know, the level of detail. If you went to your carpenter and you're like, "Can you build me a house?" and he goes, "Yeah, I can build you a house." He's not going to bog you down with, "Oh my gosh, we need this amount of 2x4 and these joists and this is a load bearing wall." You're just like, "Bro, build me a house." Right? So you don't search when you go to Google all these specific things. You search "build me a house," just like you're searching sciatica. So we have to communicate to you guys in a language that you understand. And then once we can develop a greater rapport, we can break it down, further. And, you hit the nail on the head, right? Anywhere along that tract can cause any level of quote unquote sciatica symptoms. If your sciatic nerve or your fibular nerve is stuck in your calf, you can still feel it up in through your glute. You can still feel it in your hamstring. You can still feel it yanking on your lower back in particular places. So anywhere along that nerve tract, if it's stuck, you can then feel symptoms anywhere along that nerve tract. So it's maybe not likely all the time, right? Because we can there are some rules that we can use to kind of guess from an educated standpoint in terms of where your sciatica is coming from, and we can kind of go back into that later or next episode or whatever. But as you can feel it anywhere if it's stuck anywhere, which makes it kind of complicated for us. And that's why you got to go in and actually feel things and treat things and kind of diagnostically, do some shopping to figure it out.
Yeah, this was actually a question that I got through a comment on one of the videos, which was, it was coming from someone, and I'm not sure if they had a clinical background at all, but it was quite a good question because they commented on, it was a palpation video where we were actually demonstrating palpating the sciatic nerve as it passes through the back of the hip. And for those people that are watching, whether you have or haven't seen that, that is generally the most common place that this nerve gets stuck. It just is. And there's a couple of reasons for that. I think number one, because as humans, we sit a lot. I mean, Mike and I are sitting right now, we're sitting right on top of that area. And, that leads to some decreased blood flow that comes through there. And then that is more likely to upregulate some formation of some adhesion around that nerve. It's a super, super common problem. But the question that was coming out was, how would I know if I have a sciatic nerve entrapment that is outside of the spine, or is it coming from my back and that's what's causing my sciatica symptoms? Or I would add to that as well, you could have both of those things overlaying each other. But this is a really, it's a great question, and it's not an easy one to answer. It's probably almost a whole episode on itself, right? But there's probably a couple of things that we can kind of point to, I think, just to give some ideas.
Okay, so as a very, very general rule, right? Sweeping generalization. If you're feeling it come from your foot up, that is a clue that it's coming from your lower back for me, right? If it's going from your glute down to your knee, that's more of an indication that it's going to be extra spinal. That's kind of the kind of sciatica for dummies differentiation between lower back sciatica or extra spinal sciatica. And again, I have a sciatica video that you can go and I talk about all of this really, really nicely and through my channel. If you want to go deeper from a clinical standpoint, the other thing that you can do is a straight leg raise, and it'll give you a little bit more detail. And if you're feeling sciatica symptoms from like 0 degrees to about 40, 45 degrees, that's an indication that's coming from your lower back. Anything past 45 degrees is typically an indication that it's coming extra spinally from your nerve. But the real test that somebody at home won't be able to do is to stick their thumb right and find their sciatic nerve as it exits the spine, goes through the glutes, goes down the leg, and feel it themselves. That's the gold standard. And I would say that in conjunction with now we can use sciatica to kind of like diagnostically treat that and see if it reproduces the symptoms in particular spots. But for you at home, it's either symptom location, or you can probably do straight leg raise if you have like a hamstring strap that you can stretch with it. And that would be the two ways that you can differentiate at home.
Yeah, the other thing to watch out for too might be some weakness in the foot or the leg particularly. So if you start to notice that there's issues with walking, maybe having trouble pushing off the ground, something like that, then that might be an indicator that it is coming from your back and that it's a little bit more advanced potentially too. Yeah. So that's where we really need to get that checked out.
If you've got foot drop or you're tripping over things, you probably need to see your orthopedist, right? I mean, that's 95 to 99% of the time. If you've got foot drop, you should probably see your doctor because surgery is going to be your best intervention.
The other question that I've had as well is in relation to the sciatic nerve entrapment as it pertains to the hip or the hamstrings and anywhere down the leg, is how can I get tested for this? Because I don't know if this is you as well, but you get comments from people that are potentially all around the world, and we don't have clinics all over the place. So there's a geography issue for some people in being able to get to us. But the question is, how can I get tested? How can I find out? And, can I get an MRI? That's been the question before. And an MRI is going to give us a lot of information about your lower back, basically. And it's going to tell us if you do have a disc injury and if that disc injury is impacting on nerve roots as they exit the spine. But beyond that, unfortunately, we're not going to be able to learn a lot. And one of the issues is that even if we can MRI your sciatic nerve, which can be done, we're not actually doing it dynamically. So you're laying in a tube, you're on a bed being imaged there, but there's actually no movement happening. And one of the issues with the nerve entrapment is that it's actually stopping the nerve from being able to slide and glide and move. And if you imagine that pinky finger, which is about the size of your sciatic nerve, and it has some blue tack around it, it's stuck to the muscles that it's trying to slide through. So that's the issue. And if you're in that MRI situation, it's not really going to give us much information there. And it's certainly not going to show that it's actually entrapped. So coming back to Mike's point, you pretty much need to get some hands-on treatment to verify that.
Yeah. And again, you can try it. You can go to your doctor and be like, hey, take an inclinometer and do my straight leg raise, lie on your back and have them with straight knees, flex your hip, tension your hamstring, tension your sciatic nerve. And if it's, if you can't get past 45 degrees, it's coming from your back. You can get past 45 degrees, but you can't get up to 90 degrees comfortably. That's then typically our indication that, you have an extraspinal sciatic nerve entrapment. So your nerve is stuck outside of your lower back.
All right. So this is just kind of our little way to kind of reboot this subject and get this going again, because it's a big subject. I'll throw it over to the viewers. If you've got questions about this topic, please drop it in the comments below, or check out also Dr. Mike's YouTube channel. It's Wildcard Spine and Sport. We're going to put that link down below as well. He's got some sciatica videos over there. You can drop some comments for him, give him a like and subscribe.
There's my sciatica video has, if you're already like foaming at the mouth for some exercises that you can perhaps do at home, there are a couple exercises that I do talk about in my sciatic video. So if you're not looking to wait around or you want a sneak preview of perhaps what we may be talking about in the future, check that out.
All right. So any final thoughts today, Dr. Mike?
If you're still sticking around, if you're still listening, thank you very much for spending 30 minutes with us, and look forward to having you join us for any future podcasts on sciatica.
All right. Thank you, folks. We'll see you on the next one.